Welcome back, guys. So this module is very special to me and very close to my heart. We're going to start the most intriguing ever, the most diversified, and the most tricky and difficult disease to treat as far as humankind has been facing cancer. I'm working as an oncopathologist here in Bangalore, so the amount of cancers we see on a day-to-day basis is huge. The load is huge. It's a silent killer, right? It's been there everywhere, and it's been there for years together, hundreds of years together, and still we are not able to find a solution. I hope some of you guys in future may find a solution to it. In order to reach that level, we need to know about the basics of cancer. In this entire module, we're going to see about basics of cancer. Entire, not only this module, an entire module of neoplasia is just about the basics of cancer. We're not even going into 1% of cancer which the world knows. That itself is 1% of the cancer about which we know about cancer, right? So we are just going to go to the brim, just a little bit entry about knowledge about cancer, fine? And I want you to see all the videos at a stretch if possible. I know you all guys binge on Netflix, right? Try once binge on cancer. Let's try once and binge on cancer. If possible, if you're successful, let me know, right? Okay, shall we start? Great. So for the purpose of understanding, we are going to divide them into under these groups. The first chapter or the module, what you're going to see under neoplasias, we're just going to go about about the terminologies of cancer, how I'm going to name it cancer, how it's going to look in microscopy of the cancer, second part. Third, the molecular hallmarks of cancer, how cancer is actually being formed, what are the mutations behind it, what are the different groups of mutations behind it. Fourth, known factors which cause these mutations, carcinogens. And last but not the least, how I am going to diagnose a cancer and tell to an oncologist, yes, this is this cancer and let's go and try to treat it, right? Shall we start? Okay, a big smile again and let's start. Fine. So we are going to go into the sea of neoplasia, not even sea, ocean of neoplasia. As we all know, I like only one thing. Whenever a new thing comes, break it and learn. Neo means new, plasia means growth. Neoplasia means just new growth, that's all. The first thing what you're going to see here in neoplasia is we are just going to concentrate on terminologies. Okay? How I'm going to name a tumor. Right? Just terminology, just basic terminologies. I'll go to the rock bottom basics so that just to refresh your memory. That's all. I'm sure if you're an intern or a post-intern or final year, you must have heard this, but I just want to refresh the memory. We'll start from the basics so that we don't miss anything at all. Okay? So terminologies. Whenever I talk about a cancer, I want you to remember two terminologies throughout your life. Two terminologies which is must for any cancer throughout life. And I'm talking about cancer, not a brain tumor, cancer. Those two terminologies which is must for a cancer, I generally start with them. There are two terminologies I never want you to forget. One is called as monoclonal. All cancers are monoclonal. And the second one is called as an. So I will come to the second one later, right? The first one is monoclonal, and there's one more thing as well. So it's monoclonal. We have to understand what is monoclonal, then we'll go with the definition, right? Let's take an immunoglobulin. How many immunoglobulin do you guys know? M, G, D, A, E, right? We'll take M and G. And let's suppose you're getting an infection, streptococcal infection. What immunoglobulin will come first? Ig, M. Same streptococcal infection remains in your body for like 10-20 days. It will become IgG. I'm sure all of you guys know it cross switches, right? Class switches to IgG whenever it becomes chronic. That's normal. In other words, when I have an infection, I will have more than one immunoglobulin. That is normal. More than one is called as polyclonal, right? That's polyclonal. Let's take a neoplasm which comes from plasma cells, multiple myeloma, right? In case of multiple myeloma, I will have only IgM or only IgG or only IgA, monoclonal. In other words, I am telling that the entire cancer, let it be 50 centimeter, the entire cancer has only one cell of origin. It originates from a single cell, monoclonal. That's the term. Your immunohistochemistry, your flow cytometry, your genetics, everything diagnosed based on monoclonality. I know it originates from a single cell. I'm going to use the marker of the cell to diagnose a cancer. Right? That's the basics for diagnosis. I want you to remember for sure. Right? Hope you understood. I'll keep telling and writing. If you're not understood, you'll definitely understand now, right? So the first one is monoclonal. The other one, we'll leave it blank. We're going to fill it up, right? So we'll see what does a monoclonality means. Okay, so monoclonality, I just gave you an example. Let's take an example of an infection. I took streptococcus. Let's take hepatitis for an ease. Because you know that IgG, IgM, everything happens in hepatitis, right? So for hepatitis, when I'm going to take, I will have both IgM as well as I'll have IgG. I'll have both. I'm going to call this, both will be there in infection. I'm going to call this polyclonal. In other words, when I take a cancer, I'm just writing myeloma, multiple myeloma, which is a cancer of plasma cell. I will have only IgM or only IgG or only one thing. Even if it's for first year, IgM or IgG only one will be there. This is called as monoclonal. I'm having only one. It can never be more than one. That's called as monoclonal. So the question comes is why one? Because by definition, I'm just going to write the definition of monoclonality. All the cells in a tumor originates from a single precursor. That's why it's called as monoclonal. Originates from a single precursor. There's no other cell. There's a single cell or a single precursor. That's why it's monoclonal. If multiple myeloma originates from an IgM secreting plasma cell, throughout life it will secrete only IgM. It will not class switch to IgG. I'll give you one more example. If a cancer from pituitary originates from ACTH secreting cell, it will secrete only ACTH. I'm just giving you practical examples, that's all. If a cancer from pituitary secretes prolactin, you will have a prolactinoma. It can secrete only prolactin, it cannot secrete anything else. Clear? If a cancer comes from your GIT, mucin secreting cell, it can secrete only mucin. That's monoclonality. I can base my clinical findings, I can base my IHC, everything on the base of monoclonality. That's the first thing I never want you to forget. Second is the most interesting. You guys are going to say. The second one is for my clinical examination, right? I'm sure you must have read the surgical textbook of Das for surgery clinical examination. If you've not read it, please go and read it. No book in the world is equivalent to Das. See, I love that book. The old Das, not the new one as well. Knowledge comes only from reading. Knowledge will not come just by sitting like this. If any of your friends or seniors say that they cleared the exam in flying colors within 100 ranks in a NEET PG or a distinction in an MBBS exam without reading, they are lying 100%. Take it from me, they are lying 100%. No one can be like that. You have to read, that's all. So read and we'll excel, right? Now let's come back to the portion. So monoclonal TV saw. So in your surgical textbook of Das, there'll be in chapter for examination of swelling. If you remember that, or let's leave that, you're seeing a patient and you're seeing a swelling, tiny little mass. You're palpating the swelling. When will you call that swelling, or when will you think that that swelling is a cancer? When it is soft, firm, or hard? Perfect. All of you muttered hard, right? Hard. So when it's going to be hard on clinical examination, I'm going to call or suspect a cancer. This all of you guys know. The problem is your professors would have told that why you are doing that. It's nothing is a fact. Everything is evidence based. Why is because of a property of a cancer cell. Cancer cell will elicit fibroblastic response. Whenever I have a cancer cell, it will elicit fibroblastic response. Fibroblasts, if there are plenty, I'll have lots of collagen, lots of fibrosis will become hard. That's why cancers are palpable, hard on palpation. Almost everything. There are a few exceptions for sure. I'm going to name that. You're going to name that. I'm just going to rephrase whatever I said. A cancer cell will make mass, a fibrous growth. Just two words, fibrous growth. What's the technical term for growth? Plasia. You just know so, right? What's the technical term for fibrosis? You guys know. Anatomy, the basics. In anatomy, you must have read about syndesmotic joint, right? Tibiofibular, radioulnar, fibrous joint. So fibers means desmo. Syn is uniting. Desmo is fibers, right? I'm going to name it desmoplasia. Perfect. That's the second finding. I'm just going up and writing it. The second finding for me is desmoplasia, right? Monoclonal and desmoplasia. I'm just going to write whatever I said. So desmoplasia is also a property of a cancer, which means that a cancer cell can elicit fibrosis. They have the capacity to elicit fibrosis whenever it becomes a cancer cell, whenever it invades a cancer cell, right? This, because of this fibrosis only, it becomes hard on palpation. Right? It becomes hard on palpation because of this fibrosis. That's why it's called as desmoplasia. Right? We got two things. These two things, never ever forget. Even you are on a grave, I'll come and ask you, you're going to answer, right? That time I'll be long gone. That's different. Okay? So these are two things you should never ever forget in your cancer. Now let's move on a little bit into in depth of it. I'm sure all of you know that you have tumors based on the origin of epithelium, or origin of the cell. Like epithelial tumor, I call it carcinoma. Mesenchymal tumor, I call it sarcoma. Right? We generally have a term. So we are still in terminology. Whenever I have something originate from epithelium, okay, I'm going to name a tumor which originates from the epithelium most of the time. Most of the time, I'm going to name based on the microscopic appearance. I'll also tell what does that mean. You must have heard for sure something called as a squamous cell papilloma, papillary carcinoma. Right? Papillae is an appearance. When I call something adeno, it means it will form glands. I'm not saying that adenocarcinoma comes from an adenoepithelium. There's no adenoepithelium, right? Whether it's from cuboidal or columnar, if it forms glands, I'm going to call it adenocarcinoma. So I'm going to name it based on my microscopic appearance, right? For malignancy, I'll add the term carcinoma. That's totally different. For an epithelial tumor, benign or malignant, I'm going to name based on the microscopic appearance. For example, papilloma will have papillae, and whenever anything has adenoma or adenocarcinoma, they will have glandular appearance. They will have glands appearance. This will have finger-like projection. Fine. I'm going to name based on that. When I'm going to call it cancer, same. I'll call it carcinoma. That's all. Carcinoma is a term used for cancers arising from epithelial origin. Carcinomas. Right? Carcinoma. Can I just put monoclonality inside here? I said that every tumor is monoclonal. Every cancer is monoclonal. If that is true, I can have one marker saying that all these cancers come from epithelium. Right? I'm going to say two things. IHCs for all carcinomas. See, this is sensitive. Okay? For all carcinomas, IHC is immunohistochemistry. We'll read a lot about them in future. Don't worry, it's not a new term. You'll get used to it like anything. For all carcinomas, I'm going to say something called as CK or cytokeratin. CK or cytokeratin is IHC for all carcinomas, right? One more thing I'm saying, because the second one is more practically applicable than theory, called as BER-EP4. BER-EP4 is actually a better marker than CK for carcinomas, right? More useful practical implication. Fine. So that's with carcinoma. We come to sarcoma or mesenchymal tissue. We saw about epithelium. We saw how to name. We saw the terminology used for malignancy as well. When I'm going to come to mesenchyme, I'm just going to use one more thing. When I come with mesenchyme, I'm just going to add the suffix OMA. That's all. OMA means mass. That's all. Fibroblast, fibroma. Lipid tissue, lipoma. I'm just going to add it. That's all. I'm not going to do anything. Osteoma. Cartilage, chondroma. It's not based on the appearance. It's based on the name. So what I do for mesenchymal tumor, The naming for mesenchymal tumor in general is name of the organ or name of the tissue of origin plus OMA suffix. But for epithelium, I don't use that. Papilloma, I don't call it squamosoma, right? I call it squamous cell papilloma based on appearance. Here, I use it based on the name. That's all. What I mean here is, if it's coming from fibroblast, I use the term fibroma. If it's come from your adipose tissue, I use the term lipoma, right? I'm just going to use its name and then OMA to it. Fine? That's for mesenchymal tissue. And obviously we'll need for malignancy as well. If I'm going to have something malignant in a mesenchymal tissue, I use the suffix sarcoma. Fibrosarcoma, liposarcoma, leiomyosarcoma, right? All those things are for that. Fine? Again, a terminology. So when I said one marker for epithelial tissue, obviously your mind should say, tell me what is the marker for mesenchymal tissue. IHC or immunohistochemistry marker for mesenchymal tissue is Vimentin. Okay? Again, this is a sensitive marker, not a specific marker, right? Because it's positive for every mesenchymal tumor, for sarcoma, leiomyoma, lipoma, everything. So obviously it's a sensitive marker, not a specific marker, right? So we are done with two more terminologies. I'm going to dip even more, little bit more. There are a few exceptions. See, exceptions are always MCQs. Few of the exceptions, I don't use the suffix of oma, or I don't use it as carcinoma or sarcoma. Few examples. Right? We'll just see a few examples. Let's take melanocyte. Yeah, great. Let's take a melanocyte. What is the malignancy of a melanocyte? Melanoma. Malignancy, I'm calling it melanoma. I don't have melanocarcinoma or melanosarcoma, just melanoma. So for melanocyte, the malignant counterpart is called as just melanoma. I don't use the word melanocarcinoma or sarcoma. So what is benign? Benign counterpart of a melanocytic lesion is going to be your nevus. Nevus is nothing but your mole. All of you guys have benign tumors of melanocytes. Completely fine, normal. I'm not going to be worried that I'm having a mole. Fine, normal, right? A change in terminology. I don't end any tumor with US. It's always OMA, right? Squamous, papilloma, adenoma, everything is OMA. Exception, MCQ. Next. In case of brain. See, in case of brain, what happens is, I do call it benign malignant, but I generally don't use the term carcinoma or sarcoma in the brain. I do use, not always. But in other words, what I'm going to do in brain, in CNS is, we're going to have an WHO grading system. That's how we are going to report brain. I don't say it's an glioma and gliocarcinoma. Not like that. Ependymoma, ependymocarcinoma. Not like that. I'm just going to have a WHO grading system. It grades from grade 1 to grade 4. That's the grading system for WHO. Grade 1 tumors are always benign in nature. Grade 4 tumors are always malignant in nature. When we come to CNS tumors, we will learn how to grade them. It's very simple. We are a simple mnemonic, right? We'll definitely learn how to grade. We'll look at pictures and we'll also grade tumors, right? It's very, very simple, fine? That's about brain. Again, an exception. Third exception. Third exception is the most beautiful one. Blood. Tell me a benign tumor in blood. I'll give you some time. Hemangioma is the one which came to your mind, right? No. See, hemangioma is not a blood tumor, it's a blood vessel tumor. Any benign tumor in blood. You must have spent most of your time reading hematology. Tell me a benign tumor in blood. Nothing is striking in your head, right? First, have the confidence. If you don't know something, that doesn't exist in medicine. There is no benign tumor in blood. See, confidence should be there. What will happen? Nothing will happen. Be confident. Maximum will get -1 mark. That's all right. Fine. Be confident. Not overconfident. Be confident. There is no benign tumor as such designated in blood. In blood, we have leukemias and lymphomas, right? And both are malignant. See, again, why I put it as exception is leukemia. it doesn't end with oma, right? Leukemia and lymphoma both are benign tumors. So both are malignant tumors, right? Both are malignant tumors. Langerhans cell histiocytosis, again a malignant tumor. It doesn't have oma end. So an exception, that's all, right? I'm going to have two more terminologies, just two more terminologies. Stay with me. These two terminologies are the best. Okay. The first terminology I'm going to use is hamartoma. I'll have to go a little bit background search in this thing because see, one more thing I want to say is that whenever a new edition comes, see, even I get excited whenever something new comes. But I'll tell if it is required for you. If you have to read, what is the practical purpose of that to read? This is one word which has been abused a lot. Hamartoma has been a benign neoplasm. Hamartoma is a benign tumor. Hamartoma has been a benign tumor for the past 10 plus years. But people tell that's a recent advancement. Previously, it was a misnomer. When previously? When we were in LKG. Yes, I don't bother about that. Hamartoma has always been a benign tumor. Whatever you read in your Robbins latest edition is already 5-6 years old. Okay, so nothing is an advancement for us. And one of the thing what an undergraduate does is you always go keen and waste time or read more on the advancements because thinking that advancement, it gives you an ego boost. Yes, it does. But I need to finish everything to come to the advancement, not read only the advancement, right? Remember, always be strong in your basics. Advancement will add on whenever we grow, right? That should always be the motto, not to read the advancements alone and leave the basic. A very wrong method of reading. If you're in second year, stop it right there. Don't go behind syndromes. First, know what is the definition of syndrome. Then we'll read the different syndromes, right? I want you to be very strong in basics so that no one can shake you, right? Hamartoma has always been a benign tumor. There's a definition of hamartoma as well. I'll go to the definition of hamartoma with an example, which is much easier. I'm sure a few of you would have heard a tumor called as Peutz-Jeghers polyp. Okay, Peutz-Jeghers polyp. It's an intestinal colonic polyp. I'll draw a normal intestine, how it looks. I'm writing PJ for Peutz-Jeghers. How a Peutz-Jeghers polyp looks. From the appearance, you are going to tell me the definition, right? A normal colon will have layers of epithelium, submucosa, right? Mucosa, submucosa. Then you will have muscularis, right? Then you will have serosa. General colonic thing. Mucosa, submucosa, muscularis, serosa. When I take a Peutz-Jeghers polyp is called an arborizing polyp. It looks like a tree. So it's going to look like a tree. So it'll look like this. It's a polyp that's going to look like this. With glands here. See the round chota ones are the glands. Okay, that's a polyp and this is my normal mucosa. Now you are going to compare and you are going to come with a definition. I want you to learn the definition. You define it and never you will forget it, right? So when you look at the Peutz-Jeghers polyp, the polyp also has the same components what a normal mucosa has, right? Muscle and glands, that's all. When you look at the polyp, it is big because it's a tumor, it has to be big. But the main difference between the polyp and the normal mucosa is, in the normal mucosa, look at it, the glands are on the top, right? And the muscle is below it. But in a polyp, the muscle is like this and glands are in between it. In other words, in the polyp, the glands are being splayed by the muscle. That's how it looks, right? I'm just going to write whatever I said. In the polyp, it looks like the glands are being separated by the muscles. The muscle layer. The pink one is the muscle layer, fine? The gland is being separated by the muscle layer. So that's the only difference. So I'm going to define it. You are going to define it. Hamartomas are lesion where I'm going to see normal structures, both are normal, in its normal location in colon only. In excess, obviously have to be excess, then only it will form a mass, but in a disorganized fashion. Perfect? A disorganized fashion. That's an hamartoma. Hematomas are benign tumors, always been a benign tumor. Hematomas, by definition, you defined it. Recollect whatever I'm saying, listen to whatever I'm telling, and then write the notes, right? Don't just do it mechanically. Hematomas are lesions which are composed of normal tissue. The gland and the muscle is normal, in normal location, right? In the colon, but in excess, it has to be in excess, right? And disorganized fashion. Has to be in disorganized fashion. Disorganized fashion here, what I mean here is the muscle and gland are interspersed. That's not how it looks in my normal epithelium. That's why I call it disorganized fashion. And that's the definition of hamartoma. Pute polyp is an hematomatous polyp. Few days back, I had posted a slide on Instagram, I suppose. A case of pulmonary hematoma which came in a lab. One of the most common hematoma is pulmonary hematoma. If I see one more, I'll post it later as well. Okay. Pulmonary hematoma is a pretty common one. What I see in pulmonary hematoma is excess of cartilage in the lung parenchyma. Right? I may see tiny little bit of cartilage in a bronchiole. When I see it in masses, I'm going to call it pulmonary hematoma. What I see is increase in amount of cartilage in lung parenchyma in the same disorganized fashion. That is called as a pulmonary hamartoma. Fine. That's about hamartoma. Last terminology. We're almost the fag end of terminologies. The last terminology is again pretty interesting. We call something called as choristoma. We have to see what does a choristoma mean. Okay. I always like to read the meaning of a term which I don't know. I want you to inculcate that habit as well. If something comes, you have Google. You Google very shitty things, right? Once a while, Google medicine. Enough. Not always, once a while. Choristoma's literal meaning is separate, far apart, and independent. Separate, far apart, and independent. That's the literal meaning of choristoma when it's converted to English. See, now it looks very simple. I can remember it very easily, that's all. I'll give you an example. It will fit into the name. If it doesn't fit into the name, ask me. The example is also very simple. You guys already know it. If you've read surgery, leave surgery, even in anatomy it comes. An embryological abnormality called as Meckel's diverticulum. I'm sure you must have heard that. Rule of two, you remember it, right? So Meckel's diverticulum is in persistent vitreointestinal tract, right? If you have read it in surgery, what they have told is one of the complications of Meckel's diverticulum is bleeding, right? Bleeding. And it also will be written below why it bleeds. It's said that in the microscopy, when I take a Meckel's diverticulum, I will see gastric mucosa in them. What is the function of gastric mucosa? Perfect. Gastric mucosa is going to secrete acid. When it secretes acid, what will happen to the epithelium? Ulcer. Will ulcer bleed? Yes, obviously. So that gastric mucosa in Meckel's diverticulum is called as a choristoma. Now look at the explanation. Gastric mucosa is separated from the stomach and is seen in Meckel. Gastric mucosa is far apart from the stomach, seen in the vitreointestinal tract near my colon. Far apart. Not connected embryologically. That's what I mean by far apart. Next, independent. That gastric mucosa in Meckel's still secretes acid even without the support of gastrin and the feedback mechanism. Independent. That is choristoma. Did it form a tumor in Meckel's? No. So this is a misnomer. It's just a mucosa. That's all. It's a misnomer. It will not form a mass, right? Perfect. Understood? Now let's write. Understand, perceive, make necessary changes. If you want pause, go back and come again. But make necessary changes, understand, and then only put a pen on paper. Without understanding, never do anything. Fine? Meckel's. Meckel's diverticulum, what I'm going to have is, in Meckel's diverticulum, one of the complications of Meckel's diverticulum is bleeding. The reason why Meckel's diverticulum bleeds is, you're going to have, I'm writing MX for microscopy, you're going to have gastric mucosa in Meckel's diverticulum. This gastric mucosa is going to secrete acid, that's why it functions independently. When it secretes acid, obviously there is a chance of an ulcer. I'm not saying always will have an ulcer, will have an ulcer, and this ulcer will obviously bleed. So, I'm going to call this gastric mucosa in Meckel's diverticulum as choristoma. This is called as a choristoma. It's just a tissue which is staying away from its home. That's all. Choristoma. This is a misnomer. I'm writing here as well. It's a misnomer. It's not a tumor. It's a misnomer. It's just a tissue. Same finding. I can see pancreatic tissue in esophagus. Choristoma. If something is away from its location, not doing its function, I'm going to call it choristoma. That's all, right? So we're done with the terminologies a little bit, right? We're done just with the terminologies, very basic and very sweet terminologies. Here, I'm going to take you to the next thing here, microscopy. Microscopy for a cancer. The next subdivision of the segment is microscopy for cancer. It will not take much time. It will take hardly 10 minutes. Microscopy for every cancer from head to foot will be the same. 100% it will be the same. Because we are reading general pathology. We are just going to extrapolate to different tissues later on. Right? Microscopy for cancer. Any abnormal tissue, I have 4 things in microscopy. That's all. 4 plus 1. We'll see what are the 4 things. The first and the foremost finding is pleomorphism. Again, split and learn. Pleo means many. Morphism means morphology. I am going to mean that this tumor in microscopy, they are going to look pleomorphic. In other words, I'm sure you are sitting in a classroom. Next morning or afternoon, when you go and sit in a classroom, you go to the last bench, sit there and observe everyone. Each and everyone will have a different size and shape. Say to themselves, my class is pleomorphic. Smile to yourself, be happy. That's pleomorphism. So when I look at a microscopy, though they are coming from squamous epithelium, everything will look different. That's pleomorphism. In other words, variation in size and shape of the tumor is pleomorphism. Second thing, I'm going to go give a tiny little bit of example and we are going to learn about it. I'm sure you must have seen the inflammation chapter. In that we saw every WBC how they look, right? This is one WBC. What is WBC? Perfect. Great. My drawing is good. It's improved. Neutrophil. So I have a neutrophil. At the same time, you must have read about acute myeloid leukemias. In the acute myeloid leukemias, you have some word called as blast, right? When this becomes a cancer, I'm going to have something called as blast. If you remember the blast, you must have drawn a blast like this only. Something similar to this, right? That's what you must have done. Okay? It's a blast. Nucleus, I'm giving blue color, that's all. And what are these tiny ones? Auroras. Perfect. This is a myeloblast. Great. I said, right, you are amazing. You are amazing. Because you're going to tell the second feature of a cancer without even reading the textbook. Neutrophil, blast. Carefully observe these 2 cells. You are going to tell me which of these 2 cells has more nucleus. Blast. Simple. That's the second finding. High nuclear to cytoplasmic ratio. More nucleus will be there in a malignant cell. That's my second finding. High NC ratio. I'm going to have more nuclear material in a malignant tissue. Right? High NC ratio. For the simple reason, they have to divide faster. So obviously you need more nuclear material. That's all. Right? More nuclear material, high NC ratio. When you read Robbins, it will be given, it can be 1:2 or 1:1 or 1:3. Don't come and ask me which is more malignant. That's not how I do. I don't try to micromanage medicine. It's already micromanaged to the core, right? More than normal, I'm going to call it abnormal. That's all. Fine. If you're 10 kilo also extra, also you're obese. If you're 100 kilo extra, also you're obese. That's all. Fine. I'm just going to call it high NC ratio. Third. I'm just going to write the third and fourth. I'll explain it to you with the help of an image, right? Third is going to be mitosis, related to mitosis. There are 2 things related to mitosis. One is increase in mitosis number. Just the number will be increased. Other one is called as an atypical mitosis. Fine. Next, fourth, I'm going to call it loss of polarity. These four findings I'll keep asking at least 100 times while we are going with systemic pathology. These are the only four findings required. Pleomorphism, high NC ratio, loss mitosis, and loss of polarity. We'll see what are these two guys. Third and fourth, we're going to explain and we're going to see them in the form of an image. See, look at this image alone first. Okay, there's a red circle also. In that red circle, you are seeing blue color, right? What is blue color? Nucleus. The blue color is single or divided? Divided. That's your mitosis. Remember 11th standard. You put that mitotic spindles, pull them apart. These guys are my mitotic spindles which are being pulled apart. The nucleus being pulled apart. This I am going to call it mitosis, or in other words, this is a normal mitosis, or I am going to give a term for it. I am going to call it bipolar mitosis. It's implied, right? Bipolar, towards two poles. It's being pulled and it will break and become two new cells. Simple normal mitosis. Fine? Normal. I'm going to show you one more image. Look at this image. If you look at this image, 1, 2, 3. Normal, abnormal. Abnormal. What are you going to name it? Tripolar mitosis. You're going to name whatever comes to your mind. Tripolar mitosis. Simple. I'll show you one more image. This. 1, 2, 3, 4, 5. What are you going to name? Pentapolar doesn't sound good, right? We'll call it multipolar mitosis, right? Multipolar, multiple. Not normal, that's what I mean to say here. This is multipolar mitosis. I'll show you one more cell. Look at this cell. I'll highlight it with a yellow color maybe. This entire cell, when you look at the center nucleus, it's being pulled in all different directions. The nucleus kind of becomes a ring. So I'm going to call it a ring mitosis. Right? It's a ring mitosis. So I'm just zooming out. Okay, I'm just zooming out. All the four things. The first one is normal or bipolar mitosis. This guy, this guy, this guy. All these three are abnormal. So I'm going to call all the three of them as atypical mitosis. I'll tell what do I mean by the third point. You must have read that. You must have written that increase in number of mitosis, increase in number of bipolar mitosis is also abnormal. Or any one of the atypical mitosis is abnormal. Why it is abnormal? Just imagine this top one, this guy. How many cells will he give when he divides? 3. Next one, 5. Can a single cell give rise to 5 different cells? No. If it gives rise to 5 different cells, what will happen to this organ? Big tumor. Uncontrolled proliferation of cells, neoplasia. That's all. So when I have more number of bipolar mitosis, uncontrolled proliferation of cells, when I have any atypical mitosis, uncontrolled proliferation of cells will result in a cancer. That's why it's a microscopic finding for cancer. Simple third point. The fourth point is even more amazing. You are going to tell everything. I've told you the basic rule of pink and blue and clear. That's enough to do anything in pathology. Okay? This is an image of a skin. This is skin biopsy. The normal skin biopsy. Stratified squamous epithelium, that's all. I'll put a line here and I'll put a green line on the top. The line below, what is the color? Not the line, the corresponding tissue. Blue color, right? Blue color means has nucleus, perfect. The line above, the color is pink. In other words, the below epithelium is going to have more nucleus. The top layer of the epithelium is not having any nucleus. You already know this as a fact. The top one is called a stratum corneum. And you know that stratum corneum is anucleate, right? You know the facts. Facts are the most difficult thing. This is stratum basale. Stratum basale, my nucleus is present. Stratum corneum, my nucleus is absent. That's a normal skin, by the way. In other words, when a cell from stratum basale, when it's produced, it slowly go up. It will lose its nucleus and becomes the corneal layer. So when it goes up slowly, it has to lose its nucleus. It will lose its nuclei and then only it can become stratum corneum. This is called as a normal polarity of skin. Polarity is orientation, right? This is a normal orientation of skin. If something abnormal happens to this, I'm going to call it loss of polarity. What do I mean by abnormal is when stratum corneum has a nucleus I'm going to call the guy loss of polarity. The guy should have lost his nucleus. He has not lost it, so I'm going to call it loss of polarity. Clear? That's all. I'll show you an image. You're just going to tell me only one thing, whether the polarity is maintained or not. It's also skin tissue. I'm just going to show you an image. You listen carefully, put your pens down, and tell whether the polarity is maintained or lost. This is the second image. I'll tell you, I'm drawing here. This is your topmost layer. Blue color seen or not? Yes. Nucleus present or not? Yes. Polarity maintained or lost? Lost. Loss of polarity. First part. I have loss of polarity. Look at the image carefully. Don't write. Look at the image carefully. Look at this. Small cell, big cell, medium, right? Is that pleomorphism? Absolutely yes. When I look at this few more, see, look at this nucleus. This is an entire cell. Do you have high NC ratio? Yes. What are this guy? Do you have atypical mitosis? Yes. I have pleomorphism, high NC ratio, atypical mitosis plus your loss of polarity. I have all four salient findings in this tissue. This tissue is normal or abnormal? Abnormal. This is an abnormal growth. Name it. Growth technical term is plasia. Abnormality technical term is dys. This is called dysplasia. Is it difficult? Not at all. Let medicine go to hell. Right? It's dysplasia. I am going to just name it what I'm going to see. That's all. This is going to be dysplasia. An abnormal tissue. That's all. What you have to notice here is I have not called it a cancer yet. Why is the next question. I have called it dysplastic. I have not called it a cancer. Why I am waiting to call it a cancer? Because I said you need 4 plus 1. I need the plus 1 here to call it a cancer. What is the plus 1? The plus 1 is dysplasia can have various degrees. It's graded differently in different organ systems, so we'll not go into the grading. It will have various degrees. I'm just going to write low grade and high grade dysplasia. And for our MCQ purpose, low grade dysplasias in few places are still reversible. High grade dysplasias are not reversible. You have to do a radical treatment like surgery. Okay. So if since we are dealing with squamous epithelium, skin, I'm just going with that, right? Then I have a full thickness dysplasia. The entire thickness of the squamous epithelium, all the stratified layers have become dysplastic. Full thickness dysplasia. I'm going to call this in one more name called as carcinoma. I'm not calling it cancer yet. In situ, inside. I'm having a carcinoma inside the epithelium. Still, I'm not calling it carcinoma. Why is I need to have one more important finding, that is invasion. I will call something cancer when there is an invasion into underlying structures. When there's an invasion into underlying structures, I'm going to call it a cancer. Or in other words, it's also said as invasion of basement membrane, because most of the epithelium will have basement membrane. Underlying structures or basement membrane. When I have that, I'm going to call it cancer. That's it. Fine? Clear? I'm going to tell you something. This also you know. The only problem is people don't tell you know. See, because people are afraid. That's how the entire world works. If they tell you know stuff, you will not listen to them. I don't mind because I'm not going to see you ever. And you're never my competition. If you compete, I will also read, you also read. Better one will win, that's all. Fine? I'm telling you this also you know. When you went to your first surgery ward, first posting will be enthusiasm, right? You must have pressed an ulcer case. Most of them ulcer case only. The investigation will be biopsy. The surgeon would have asked, where do you take the biopsy from? Center of the ulcer or periphery of the ulcer? All of you must have told edge of the ulcer. Why? Because so and so person taught me, so and so book gives me. Simple reason is, I have an ulcer. In the center of the ulcer, the underlying tissue is present or not? Not present. Can you demonstrate invasion? No, because it's a dead tissue. Corner of the ulcer, I'm having abnormal tissue plus I'm having normal tissue. Can you demonstrate invasion? Yes. Can I say whether it's a cancer or not? Yes. And why do you take a biopsy in a long-standing ulcer? To document malignant transformation. Do you guys know this? Yes. Why are you afraid? Middle finger to all the exams and go ahead and give the exam, right? You know everything. You know this, but you don't know that you know that. Invasion of basement membrane is a characteristic finding in a malignancy. Most important in a malignancy. I'll tell one more thing as well. One is invasion, other one is metastasis. Both are characteristic feature or the hallmark for malignancy or characteristic finding in a malignancy. Okay? They are characteristic features in a malignancy. Fine. Sometimes I hate entrance teaching for the only reason that people play with words. They are going to say that which is best among this. Your some person will create a confusion, have a wrong recall from an exam, and ask which is best for this invasion or metastasis. And you'll have people giving 10 screenshots of 10 books and saying, yeah, I read in this book, this is more important. This is like asking which eye you look to see, right eye or left eye. Both eyes are important. Both are important. I cannot differentiate. You ask any practicing pathologist, they'll say, what sort of stupid question is this? Because it's a stupid question. It was not asked in exams. It's a memory-based recall error. That's all. So don't go into controversies. Wastage of time. Totally waste of time. Medicine has controversies, but it's going to be later part of your life when you become a professor, not now. Now, if it's a controversy, it's a recall error. 100% is a recall error. Fine. None of the exams have controversies. Take it from me. Or if you don't believe me, ask your seniors who wrote exam. Ask them how many controversial questions came in an exam. If they say more than one or more than two, I'll stop teaching. Because it's bluff. It doesn't come. They don't know the answer maybe, but controversial questions doesn't come. If it's a controversial, they'll give you mark. Both are characteristic feature of a cancer. Fine? That's it. I just want to write one more thing here. Now I'm going to go to microscopy. We took an example of a squamous cell carcinoma and squamous epithelium. So invasion is when it goes below the basement membrane into dermis, I will call it a cancer, right? I'm a stupid pathologist. For me, I need proof for everything. So I'm saying that how will you say it's invasion? I'll ask you the question, how will you say it's invasion? I will say it's not an invasion. You have to prove. So what I have to do is, I have to stain the basement membrane. Unfortunately, basement membrane is made of collagen. Dermis is also made of collagen. So in a routine H&E stain, I will not be able to see the difference, right? I will not be able to see. If I am not able to see a difference or diagnose something on H&E, what do I do? Perfect, I need a special stain. So that comes an MCQ. Microscopy, to demonstrate invasion, I need a special stain which is going to highlight my basement membrane better, which is our famous PAS. PAS highlights the basement membrane, so it makes the invasion more evident, that's all. I'll show an image of the same squamous epithelium highlighted by PAS. Okay? This is same squamous epithelium highlighted by PAS. It's written EBM, right? EBM stands for your epithelial basement membrane. So here, I'm just using yellow colors for contrast. Can you see a thin line here? Yes, you can see a thin line. Right? You can see a thin dark line. That's my epithelial basement membrane. Why this is important is, let's assume I have one cell here. I think it's visible. We'll put it in black. I have 2 or 3 cells coming below the basement membrane. Can I say with confidence it's invaded the basement membrane? Absolutely yes. That's why it helps me, that's all. When a pathologist is in doubt, I'm going to use this. If I'm going to use this, I will ask that in an MCQ as well. Fine? So that ends the microscopic appearance of a cancer. Everything you require for a microscopic appearance of cancer is done with. Right? So look here. This is where we stop with. I'm just going to go through fastly whatever I said before. When all these 4 are present, I'm going to call this dysplasia, fantastic 4. And we saw about low grade, high grade. And you have to know something called as carcinoma in situ. To call it carcinoma or cancer, I need one important guy, which is invasion. When invasion is present, I'm going to call the guy cancer. That's all, right? That's about microscopic appearance of a cancer. Is my job done with that? No. My job is not done with saying just it's a cancer. I'm the person who's going to say whether it's a good cancer or a bad cancer. Based on that, the oncologist will treat. So how do I say it's good cancer or bad cancer? That's where comes the next thing called as differentiation. 3 more minutes, then we'll stop this module, right? I need to know something called as differentiation. So I'm going to introduce 2 words for you: grade and stage of a tumor. Stages is generally, it's universal now, except for a few. Most of them are TNM. Stage is both clinical, imaging. PET scan has become a very important role in staging, imaging wise, and also microscopy. All 3 are required for staging a cancer. Grading is completely microscopic. So what does grading and what does differentiation means? To understand grading, we need to know what is differentiation. Right? We need to know what is a differentiation. Differentiation is if the cell does its function, I'm going to call it well differentiated. For example, I'm having a gland which is producing good amount of mucin, well differentiated gland. I'll call it well differentiated adenocarcinoma. Not giving mucin at all, poorly differentiated. Okay mucin, moderately differentiated. So differentiation or grading is based on if the tumor functionally resembles the parent cell of origin. Okay, resembles the parent cell of origin. I'm going to call it well differentiated. And well differentiated tumors will generally have a good prognosis. Okay, that's all is about differentiation. Differentiation is based on well, moderately, and poor in most of the cancers. Right? I just want you to know what is differentiation and what does it mean. Well differentiated means the cancer cell is doing the function of the parent cell. It's well differentiated. If plasma cell myeloma secretes immunoglobulin, well differentiated. There are few plasma cell myelomas which will not secrete immunoglobulin, poorly differentiated. Right? That's what well and poorly means. Fine? Just an example. One more terminology, last word, I'm going to finish it. When I'm going to use the word anaplasia, ana is absent, plasia is growth. Here I'm going to use the plasia for differentiation. When there is lack of differentiation, I'm going to call it anaplasia. I'm looking at a tumor in microscopy. I'm not able to say what cell it is, anaplastic. I don't even know what it is, anaplastic. Anaplasia is total lack of differentiation. I don't even know what is cell, but I'm not sure it's epithelium or mesenchyme also. That much poor differentiation, right? That's anaplastic. Whenever you see this term anaplasia in any cancer, you can close your eyes and write poor prognosis. Okay, close your eyes and write poor prognosis. 100% poor prognosis. Next word is just for an MCQ because Robbins uses this term, so I'm using it. Otherwise, I will not use it. Anaplasia is also called as an hallmark of malignancy. Okay, that's also called as an hallmark of malignancy. Fine, that's with it. So in this first module, you have successfully completed how to name a tumor. So if I give a slide without saying anything, you should be able to name that. That's all is the role for the first module. And also, I have told you how to differentiate a normal tumor from an abnormal tumor. Normal tumor from a normal cell. Right? When I'm going to have a cancer, 4 features: pleomorphism, high incidence ratio, mitosis, and loss of polarity. Plus invasion, call it cancer. That's all. So we know 2 things by the end of this module: terminology and microscopy. Tick, check. Okay? Now go take a cup of coffee. See, this time take coffee mug and keep near you. I want you to binge watch the entire Neoplasia, right? Go back, have a sip, and go back to the next video. And till then, bye-bye from Dr. Ajit. Bye-bye.